next topic is reactivation of hepatitis B, C after chemotherapy by Dr. Anil Chandra Anand. He is a veteran surgeon, Vice Admiral, Emeritus Professor, Kalinga Institute of Medical Sciences, Bhubaneswar, Editor-in-Chief, Journal of Clinical and Experimental Hepatology, and his research interest is hepatitis, cirrhosis, and liver transplantation. So over to Dr. Anand, please.
Thank you very much, sir. It's a great pleasure to be here, and I'm grateful to Dr. Sanjay for this opportunity. Can you hear me? My voice is a little bad because of bad throat. Can you hear me? Okay. I will try to, in next 12 minutes or so, I will try to touch upon some important aspects of HBV and HCV reactivation after chemotherapy. This is my outline of the talk. I was told that it's going to be a mixed crowd, and therefore I've kept the talk very basic so that only the essentials have been included. I'll talk about a little bit about prevalence, immunity and HBV, guidelines about it, basics of HCV, and the take-home message. When we talk about cancer chemotherapy, it also includes any type of immunosuppression that is given to the patient, even after transplantation, or treatment of immunological diseases like the biologicals we are using these days, immunomodulators, biologics I mentioned, immunotherapy that is being given these days, and CAR T cells and the newer forms of therapies that have come in for treatment of cancers. Now, hepatitis B virus reactivation is a well-known risk during chemotherapy for hematological malignancies with reported rates ranging between 14 to 72%. 48% on an average if surface antigen is positive, and 18% in case of past infection, people who are surface antigen negative. And there are guidelines available for management of these patients. HCV reactivation has been reported in about 23% cases in HCV infected patients who receive cancer treatment. As I told you, INASL published guidelines in 2018, and 2-3 years later, APASL also published guidelines on this. And this issue is important world over, and the guidelines from ASLD and European societies have also been published earlier. Now, chronic viral hepatitis in India, when the guidelines were made, these were the figures which are quoted at that time, around average of 4% hepatitis B virus prevalence. And E antigen negative, 90% of them. Anti-core positive, 8 to 18% of population. That means past exposure is present in almost 24 to 70% cases in population. That means if we study a population from this, say 100 people sitting in this hall, more than half of them may be having past infection which has been cleared. And these people are also at risk of developing complications while chemotherapy is being given. Today the figures have gone much lower down. Hepatitis B virus prevalence in India today is reported as 0.89 to 1.01%. And HCV prevalence is reported as 0.32%, and these are the national figures which have been published on the national websites. Let me talk a little bit about hepatitis B virus and the host immunity. Hepatitis B is a DNA virus, as we all know, and it is capable of integrating into human genome. There is an article which was published a few years back which talked about the stealth and cunning of hepatitis B. The relationship between human immunity and hepatitis B is that of spy versus spy comics that you must have read in your childhood. It's a small piece of DNA which can deceive human immunity. For example, it manufactures surface antigen far in excess of its need. And this is to neutralize the antibodies against hepatitis B. And this is the same technology which air forces also are using now to deceive the missiles which are following. They eject a lot of flares, and the missiles keep following the flares while the aircraft flies in a different direction. This is another diagram which has been published, which looks very complicated, and I'm not going to discuss this diagram in detail, but I'll give you the message that comes along with it. The message is that hepatitis B virus suppression can suppress type 1 interferon production. Hepatitis B virus affects the function of dendritic cells. Hepatitis B virus affects the function of macrophages. It can affect the function of neutrophils, and it can affect the function of natural killer cells. And therefore, when a child is born or when a young person develops hepatitis B virus infection, it can overwhelm the immunity, and that is why it is called the immunotolerant phase, because the body in childhood, the hepatitis B virus is not recognized by the immunity. It's only after about 10 to 30 years that we have an immune clearance phase which follows, in which the body tries to clear the virus. And this is the time when the clinical infection can be seen. That is, you can have a liver failure or viral hepatitis that is usually observed. And once this has gone over, after that, the virus hides in the nucleus. It hides in form of a cccDNA, which is, and clinically the condition is known as inactive carrier. These people are surface antigen positive, but DNA negative. And a stage after this is the reactivation, which usually follows with the chemotherapy. And the last stage is occult HBV infection, in which very small amount of DNA is left while surface antigen is cleared, what we call as functional cure, and these people are also prone to develop reactivation during chemotherapy. Now, cccDNA acts like a sleeper cell. Normally, it is a partially double-stranded DNA in the virus. It becomes completely circular DNA, and this is what is called covalent circular DNA, which is the cccDNA, which can form as a microchromosome and stay in the nucleus, or it can get integrated into the human genome and keep manufacturing the virus whenever the situation is better. So, what is the HBV reactivation? It is diagnosed when a patient with serological evidence of hepatitis B virus develops any of the following: a detectable HBV DNA level which was previously undetectable, or a rise in DNA levels more than 2 logs when the patient who had either detectable DNA or very low levels of DNA. And reverse seroconversion, that is, a person who was surface antigen negative becomes surface antigen positive, or a person who was E antigen negative becomes E antigen positive. This is called reverse seroconversion. So for governing reactivation, there are 2 main factors which are required. That is, one is viral activity, and second is the immune status of the patient. If a person has cleared the virus, only rudimentary cccDNA is available. Whenever chemotherapy is given, the immunosuppression occurs, as a result of which the virus starts multiplying again and the viral DNA keeps rising. At this stage, nothing much happens except that viral DNA is silently going up. But whenever the chemotherapy is stopped, or when there is a gap between the chemotherapy levels, the immunity comes back again, and this is the time immunity tries to kill the virus, and it kills all the hepatocytes which are infected, causing liver failure. So, viral activity, the maximum risk of reactivation occurs when the person is core antibody positive, surface antibody positive, surface antigen positive, and DNA also positive. It is moderate risk of reactivation when only core antibody and surface antigen is positive and DNA is negative. And if only core antibody is positive and surface antigen and DNA are negative, there is a low risk of reactivation. So this is one aspect of reactivation, that is the risk of viral activation. The other aspect is what kind of immunosuppression we are using. The various kinds of immunosuppression have differing effect on the immune function of the body. For example, when we are giving stem cell transplantation or solid organ transplantation, this causes maximum immunosuppression. Corticosteroids, when they are given in high dose, moderately severe immunosuppression. Biologics, low moderate immunosuppression. If you are using azathioprine, low risk of immunosuppression and therefore low risk of reactivation. So various guidelines have tried to classify what should be done in these situations. All patients who need chemotherapy, immunosuppressive therapy, or solid organ transplant need to be screened for surface antigen and anti-hepatitis B core antibody. If they are surface antigen positive, they are high risk for reactivation. And if they are surface antigen negative but anti-core antibody positive, then they are low risk of reactivation, and such patients still need hepatitis B vaccination. If surface antigen positive patient is the one who is undergoing immunosuppression, it is recommended that there is a very high risk of reactivation, and therefore this patient should be treated for hepatitis B virus with the standard drugs, and the treatment should be continued 12 to 18 months after stoppage of chemotherapy. For a person who is surface antigen negative and anti-core antibody positive, if they are given immunosuppressive therapy, they also are high risk for reactivation if it is lymphoma or stem cell therapy which is being given, and they need to be, they should be, low risk patients should be monitored with ALT, surface antigen as well as DNA, and one should start treatment if any of these things become positive. So this is the slide which will summarize the whole thing. Depending on what kind of immunosuppression is used, the risk is assessed, and depending on what is the situation of the virus at the onset of chemotherapy, that is how we assess the risk of reactivation, and a preemptive therapy for hepatitis B is started. This is again calculated risk in various type of immunosuppressive therapies. I am not going to go into details of this. The newer type of therapies which have come in, they also indicate moderate to severe risk, and therefore in these cases also hepatitis B virus treatment is recommended. What really happens if the hepatitis B virus recommendation happens? You can have a death from liver failure, you can have requirement of ICU care because of acute liver failure. Patients would need to be hospitalized when the chemotherapy was being given as an outpatient. A patient may develop jaundice, and you may have to drop chemotherapy, and the treatment for virus, the cancer would be suffering. So if you give preemptive treatment, you can reduce the risk of reactivation from 87% down to about 10 to 15%. And you can reduce the chances of mortality because of hepatitis B virus reactivation. What drugs to be used? The drugs with high genetic barrier for resistance, that is entecavir and tenofovir, are the only drugs which are recommended for treatment in such a situation. If a person has already been vaccinated but his titers are just around 10 international unit, they need to be probably revaccinated, and depending on the risk of treatment which is there. For hepatitis C virus, the situation is not so bad, because once hepatitis B virus is treated, it does not have a mechanism like cccDNA, and therefore it does not leave behind any traces in the body. So hepatitis C virus is slower but equally sinister, because it can also suppress human immune system. And whenever there is a co-infection with hepatitis B and hepatitis C, if you treat hepatitis C virus first, person can have reactivation of hepatitis B virus, and therefore the treatment for hepatitis B virus should be started at least 2 weeks earlier than treatment for hepatitis C virus. It is very effective. DAA treatments are available. And this is what I mentioned about reactivation can occur when there is a co-infection of B and C. If you treat hepatitis C virus earlier, B virus can get reactivated. Now, definitions in terms of hepatitis C are a quiescent HCV infection. I'll just take 2 minutes more. Quiescent HCV infection, that is positive HCV RNA is present, but patient is asymptomatic. HCV reactivation is when RNA levels rise during chemotherapy more than 1 log, and HCV related hepatitis flare is when ALT levels rise more than 3 times. Reports of hepatitis C virus reactivation are less, but they have been there, and therefore it is good to look for hepatitis C virus also before starting the chemotherapy. And the management is very simple. That is, you check for HCV antibody. If it is positive, check for HCV RNA. If it is detectable, you need to treat it unless there are some contraindications present. These are the contraindications for DAA therapy. So my take-home message is all patients undergoing immunosuppressive therapy should be screened for evidence of hepatitis B and C virus infection. Risk for viral reactivation should be assessed before starting immunosuppressive therapy. All those at high and moderate risk of HBV reactivation should be given preemptive treatment with the drugs that have high barrier to genetic resistance, and treatment should be continued for at least 12 months after stopping the immunosuppressive therapy. All those HCV RNA positive should also be treated with DAA therapy. Thank you very much.
Thank you, sir, for very nice presentation. Any question and comments? Only 1 or 2 questions can we allow because of paucity of time.
Hello. 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 Yeah. Sir, in a patient who is receiving immunosuppressive therapy, reactivation can be silent with OTPT elevation, with jaundice, or with basically severe like hepatic failure. There are 3-4 type of reactivation. So silent reactivation should be treated or not? Because otherwise, if you go by a definition of APSL 2015, all patients who have got normal fibroscan, normal OTPT, and DNA up to tune of 20,000 international units should not be treated.
No.
So why they should be treated?
No, it's not true. There are 2 words which are used. One is reactivation, which means rising DNA levels, which may be asymptomatic. Second is called flare. Flare is rise in ALT levels. When the immune system is suppressed, the HBV infected cells have not been killed. Therefore, there is no rise in ALT. This is the stage when it should be treated. Whenever the patient is asymptomatic and the DNA level is rising, he should be given preemptive treatment. Otherwise, whenever the immune levels rise after the chemotherapy is over, patient will have a severe reaction and patient may have acute liver failure.
So you mean to say there is no silent elevation of DNA? All patients will eventually have OTPT elevation. They will have severe form of disease. Yeah. Okay.
This is more of a comment rather than a question. The commonest immunosuppression is with corticosteroids, and we are using corticosteroids for majority of the indications, where the doses are more than 30 milligram per day for 6 weeks, 8 weeks, 3 months, and sometimes even more than that. So one of the common observation is that many times we don't go for B and C before starting this 30 milligram dose of steroid. So for all of us, we should be aware that whenever we are starting steroid in the doses of 30 plus for at least 6 to 8 weeks or 2 months, for many conditions, all of us know that. So B and C screening should always be done so that this reactivation could be considered. Otherwise, we will miss.
I fully agree with you, sir. Steroids, when they are given less than 20 milligrams for less than 2 weeks, are considered low risk for reactivation. But whenever they are given at higher dose and for longer duration, they are a high risk for reactivation. And what you said is absolutely true. In all those cases, we should check for hepatitis B and C before treatment. Thank you very much.
Thank you, Dr.